Good morning, everyone. I'm Dr. Hia Boro. I'm a practicing endocrinologist at Sharjah, UAE. Together with Dr. Mazza Dalvi and Dr. Velmurugan, we shall be covering a few high-ill topics for MRCP exams. So, MRCP exams, as we already know, it consists of part one and part two exams, followed by the practical exams, which are the PACEs. So, initially, we shall be covering the high-ill topics for MRCP part one and part two theory exams. So today I shall be covering the infectious disease part. Let's begin. So question number one, a 24-year female is admitted to the hospital with fever, chills, and muscle pain. She reported being bitten by her rabbit 4 days ago. Upon examination, an ulcer was observed at the bite site along with tender regional lymph nodes. Closer inspection revealed pus draining from the lymph nodes. So she is a female who was bitten by her rabbit 4 days ago, and there's an ulcer at the bite site, and there is also tender regional lymph nodes. So the lab evaluation gives us a picture of infection with raised WBC count, and other liver function and kidney functions are more or less okay. ALT is slightly elevated. Creatine kinase and albumin are within range. So, what is the most likely diagnosis in this patient? Options are Legionella, Mycoplasma, tularemia, psittacosis, and leptospirosis. I repeat, Legionella, Mycoplasma, tularemia, psittacosis, and leptospirosis. So the hints here are the patient was bitten by a rabbit and there is an ulcer formation at the bite site along with regional tender lymph nodes, and there is evidence of infection on the lab results. So the answer is tularemia. Now let's discuss what is tularemia. Tularemia is a zoonotic infection that is caused by animal bites, and the bacteria which is responsible is known as Francisella tularensis. It is generally transmitted through lagomorphs like rabbits, hares, and pikas, and aquatic rodents like beavers and muskrats. Tularemia can also be transmitted by tick bites. It generally presents with an erythematous papulo-ulcerative lesion at the bite site, and there can be reactive and ulcerating regional lymphadenopathy. And the treatment of choice is with antibiotics. Doxycycline is the antibiotic of choice. So these are some of the pictures of the ulcer that can form at the bite site of tularemia patients. So as we can see here, it is the blackening of the nail, and in the legs we can see an ulcerated lesion, and even on the face we can see an ulcerated lesion. And what about the other options like psittacosis, Legionella, and Mycoplasma? Psittacosis, Legionella, and Mycoplasma, as we know, they usually present with atypical pneumonia. And leptospirosis, on the other hand, is usually transmitted when the patient comes in contact with a vermin. And leptospirosis is more common when the patient comes in contact with rat urine, particularly during the time of floods. And leptospirosis can present with serious involvement of liver disease. There can be even cases of acute hepatic failure, thrombocytopenia, and acute kidney injury. Although there was some amount of liver involvement in this patient, however, acute kidney injury was not present. Now, let us discuss what are the different types of bites. The animal bites, the majority of the cases involve dogs and cats because they are the commonly found animals around the road. And dog and cat bites are typically polymicrobial, and the most common isolated organism is Pasteurella multocida. So remember, it can be asked as a question, what is the most common isolated organism in animal bite? So it is Pasteurella multocida. And how do you manage an animal bite? The first and foremost thing is that you have to cleanse the wound. And one important thing is that do not suture the puncture wounds unless cosmesis is at risk. And the first line antibiotic is coamoxiclav, that is a combination of amoxicillin and clavulanic acid. The common brand name that we know, such as Augmentin, etc. And if the patient is having penicillin allergy, then we can consider giving doxycycline and metronidazole. So remember that the first line antibiotic for all animal bites is coamoxiclav. Now, what about human bites? Human bites are also typically multimicrobial. It involves both aerobic and anaerobic bacteria. The common organisms that are isolated in human bites are Streptococcus species, Staphylococcus, Eikenella, Fusobacterium, and Prevotella. Just like the management of animal bites, in human bites also the antibiotic of choice is coamoxiclav. However, in human bites you have to consider risks of HIV, hepatitis C as well. So whenever there is a human bite, you need to test for HIV and hepatitis C as well. Okay, now come to the next question, question number 2. So this is a 30-year-old male who recently returned to the UK after a trip to Kenya. Uh, During the time of his travel, he did not take any anti-malarial prophylaxis and he sustained multiple mosquito bites during his trip. He currently has a fever, but he's otherwise stable. Malaria has been confirmed via a rapid antigen test, and additional test results are pending. Which of the following findings would indicate that he should be treated for severe malaria? So you just read the question. The patient went to Africa and he sustained multiple mosquito bites. After returning from Africa, he had a fever and he underwent investigations, and malaria has been confirmed with a rapid antigen test. So what is the question asking? Which of the following would indicate severe malaria? So for this, you have to know the criteria for severe malaria. Now the options given are temperature more than 38 degrees Celsius after antipyretics, Plasmodium vivax species in blood film, CRP more than 300, blood glucose of 18 millimole per liter, and parasitemia of 6%. So let's see what's the answer. Try to guess. Well, the answer is parasitemia of 6%. Okay, so according to the UK guidelines, these are the diagnostic criteria for severe malaria. Now, there are certain clinical criteria as well as there are certain lab criteria. So, among the clinical criteria, we have the patient should have the following clinical features like prostration, confusion or agitation with a GCS score of more than 11. So, remember the GCS score should be more than 11. It's not sorry, the GCS score is more than 11, but the patient is having confusion or agitation. And if the patient slips into coma with a GCS score of less than or equal to 11, or in the coma scale if it is less than 3 in children, if the patient is having respiratory distress like acidotic breathing, patient is having convulsions, patient is having shock with a prolonged capillary refill time of more than 2 seconds, with or without systolic blood pressure of less than 80 millimeter in adults and less than 70 millimeter in children. Pulmonary edema, which should be confirmed radiologically, abnormal bleeding, jaundice, anuria, and repeated vomiting. So these are the clinical criteria of severe malaria. I repeat, the patient should have prostration, confusion or agitation with a GCS score of more than 11, coma with a GCS score of less than 11 with a coma scale of less than 3 in children, acidotic breathing, convulsions, shock with a capillary refill time of more than 2 seconds, and blood pressure, systolic blood pressure less than 80 in adults and less than 70 in children, pulmonary edema, abdominal bleeding, jaundice, anuria, and repeated vomiting. Now, coming to the lab criteria, hemoglobin less than 7 gram per dl in adults and less than 5 gram per dl in children, hemoglobinuria, hypoglycemia, a glucose level less than 2.2 millimole per liter or less than 40 milligram per deciliter, acidosis, that is base deficit of more than 8 milliequivalent per liter, or plasma bicarbonate less than 15, or venous plasma lactate more than 5. So remember, acidosis with a base deficit of more than 8, bicarb less than 15, or plasma lactate of more than 5. Acute kidney injury with a creatinine of more than 3 milligram, or urea more than 20 millimole. Asexual parasitemia, which was asked in the question of more than 10% of infected RBCs. However, in the UK guidelines, the cutoff is 2%. So remember that the UK guidelines, it is 2%. So here the answer is parasitemia of 6%. For the UK guidelines, the cutoff is 2%. So these are the criteria for severe malaria. Very, very important question for MRCP because this question has been asked repeatedly. And you need to remember all the criteria for severe malaria. Now, how do we treat severe malaria? IV artesunate therapy is the treatment of choice in severe malaria. The person may require ICU when ICU or HDU admission. He should be monitored very closely, and IV fluids and IV artesunate therapy are the treatment of choice for severe malaria. Now, coming to falciparum malaria, as we know that most of the cases of severe malaria are caused by Plasmodium falciparum species. So, falciparum malaria can lead to serious complications like cerebral malaria, which is a very dangerous condition. This may result in prostration, confusion, coma, seizures. It can also cause acute kidney injury. Something which is known as black water fever. So, in black water fever, basically the patient is passing black urine because of hemoglobinuria, and this hemoglobinuria occurs because of intravascular hemolysis. The patient can also present with acute respiratory distress, hypoglycemia. So remember, the cutoff is less than 40 milligram per deciliter or less than 2.2 millimole per liter. That is the hypoglycemia criteria. And one of the most serious complications is disseminated intravascular coagulation. Now, what is the treatment of uncomplicated falciparum malaria? So, even in uncomplicated falciparum malaria, there has been found chloroquine resistance in parts of Africa, particularly. So, even in uncomplicated falciparum malaria, we prefer artemisinin-based combination therapy. So, there are various types of artemisinin-based combination therapy, like, for example, artemether lumefantrine, artesunate amlodipine, artesunate mefloquine, artesunate and sulfadoxine pyrimethamine, dihydroartemisinin plus piperacin. So among any of these artemisinin based combination therapy we can use for uncomplicated falciparum malaria. Now, the treatment of complicated falciparum malaria. So, when the parasite count is more than 2%, the patient requires parenteral treatment regardless of the clinical state. So, always remember the parasite count is more than 2%, patient will require parenteral treatment, not the oral artemisinin combination therapy. And the WHO recommendation is that intravenous artesunate is nowadays preferred over intravenous quinine. Quinine we used to give in earlier days, but because of certain side effects of quinine, particularly on the heart, it is now being replaced by intravenous artesunate. And the parasite count is too high. If it is more than 10%, then you can consider exchange transfusion. Okay, so that was about malaria. Now coming to the next question, that is question number 3. Now, this is a 24-year-old woman who presents to the sexual health clinic with a 3-day history of dysuria and vaginal discharge. Her medical history includes migraine and asthma. She is currently taking sumatriptan and uses a fluticasone inhaler. She has no known drug allergies. A vulvovaginal swab is collected and tested using nucleic acid amplification, which confirms a diagnosis of chlamydia trachomatis. So, what is the most appropriate antibiotic to initiate? So, what is the question asking? Now, this is a 24-year-old female who is sexually active and she presents with some vaginal discharge and dysuria, which is with a very short history of 3 days. Medical history includes migraines and asthma, and she is currently taking some migraine drugs and one inhaler for asthma. She undergoes the swab testing and it reveals the diagnosis of chlamydia. So it is asking the most appropriate antibiotic to treat for chlamydia. The options are amoxicillin, azithromycin, doxycycline, ceftriaxone, or ciprofloxacin. Think about this. Yes, the answer is C, that is doxycycline. The first line treatment for chlamydia is doxycycline. So, doxycycline is nowadays recommended as the first line treatment for chlamydia. Previously, azithromycin was used, but due to the rising rates of Mycoplasma genitalium co-infection, there is a lot of macrolide resistance. So, that is why doxycycline is preferred over azithromycin. So, remember the first line treatment for chlamydia is doxycycline. However, in pregnancy, doxycycline is contraindicated. So, amoxicillin is used in pregnancy when doxycycline is contraindicated. Azithromycin is also preferred over amoxicillin in pregnancy. So, amoxicillin can be used in pregnancy, but the drug of choice for chlamydia in pregnancy is azithromycin. Other antibiotics like ceftriaxone is a first-line treatment agent for gonorrhea and not chlamydia. So remember, so first-line treatment for gonorrhea is ceftriaxone, and it is administered as a single intramuscular dose. Ciprofloxacin has no role in chlamydia treatment. So to summarize, doxycycline is the first-line treatment for chlamydia without pregnancy. In pregnancy, the first-line treatment for chlamydia is azithromycin. Ceftriaxone is a drug of choice for gonorrhea and not chlamydia. Ceftriaxone is administered as a single intramuscular dose in gonorrhea. Now let us discuss a little bit about chlamydia. Chlamydia is the most prevalent STI in the UK. It is caused by Chlamydia trachomatis, which is an obligate intracellular pathogen. It affects approximately 1 in 10 young women in the UK. The incubation period is 7 to 21 days, and many cases are asymptomatic. Clinical features of chlamydia infection, it is asymptomatic in 70% of women and 50% of men. If symptomatic in women, it can present with cervicitis like bleeding, discharge, dysuria, and in men, it can present again with urethral discharge and dysuria. Now, what are the complications of chlamydia infection? So, chlamydia can lead to certain complications like epididymitis in males, pelvic inflammatory disease in females, endometritis, increased risk of ectopic pregnancies, infertility, and sometimes it can lead to a systemic inflammatory reaction in the form of reactive arthritis. And one of the serious complications of chlamydia infection is perihepatitis, which is known as the Fitz-Hugh-Curtis syndrome. So just remember the Fitz-Hugh-Curtis syndrome, which is a perihepatitis following chlamydial infection. What is the investigation of choice for chlamydia? The investigation of choice for chlamydia is nucleic acid amplification test. You test this with the first void urine or vulvovaginal or cervical swab. In women, the vulvovaginal swab is used. For men, urine testing is done. And testing should usually occur 2 weeks post exposure. Now, the screening for chlamydia infection, the National Chlamydia Screening Program is open to all men and women aged 15 to 24. And the 2009 SIGN guidelines recommend that screening should be done in all sexually active patients aged 15 to 24, with opportunistic testing being the key. Now, how do you manage chlamydia infection? So, I've already mentioned doxycycline 7-day course is the first line treatment. So, doxycycline to be given for 7 days. It is preferred over azithromycin because of Mycoplasma genitalium co-infection and with a lot of macrolide resistance. If doxycycline is contraindicated because of some reasons, then use azithromycin. In pregnancy, the drug of choice is azithromycin and not doxycycline. Now, what about partner notification for chlamydia infection? The initial partner notification, the patient should be given a choice to attend the trained practice nurses or referral to the genitourinary medicine clinic. For men with urethral symptoms, notify all the contacts from 4 weeks prior to symptoms. For women and asymptomatic men, notify partners from the last 6 months or the most recent partner. So you have to notify all the partners that person is having. And contacts should be treated before even the result tests are confirmed. So this is very important that the contacts, all the contacts of the patient should be treated even before the result tests are confirmed. So this is how chlamydia looks like. It is an obligate intracellular pathogen, and sometimes in MRCP part 2, you may be given pictures of the such kind of pictures, and so you have to identify the organism. So chlamydia is basically an obligate intracellular pathogen, and the test of choice is nucleic acid amplification test, which is done on urine test in case of males or a vulvovaginal swab in case of females. Now coming to the next question, question number 4. Which one of the following vaccines uses a protein that attaches to the polysaccharide outer coat to make the pathogen more immunogenic? So this is a question on vaccine. So it is asking about a type of vaccine which uses a protein coat that attaches to the polysaccharide content to make the pathogen immunogenic. The answers are, the options are rabies, yellow fever, oral polio, measles, or meningococcus. Now let's see what the answer is. Answer is E, that is meningococcus. Now, see, there are various types of vaccines. So, let us first understand the different types of vaccines. The commonly used types of vaccines are live attenuated vaccines. The live attenuated vaccines, they utilize a weakened form of the pathogen to stimulate an immune response similar to a natural infection. So, here in this type of vaccine, the pathogen is live, but it is altered so much that it is not severe enough to cause the disease. The advantage is that it triggers a very strong, life lasting immune response. And the contraindications of live attenuated vaccine is that patients with compromised immune systems should not take this vaccine because of the live nature of the vaccine. Because the vaccine is live, so patients who are having compromised immune system, they may manifest severe form of the disease. Examples of live attenuated vaccines, the very famous BCG vaccine for tuberculosis, MMR vaccine, which is the measles, mumps, and rubella vaccine, influenza intranasal. Now, see, the influenza vaccine is of various types. The intranasal influenza vaccine, it is a live attenuated vaccine. Oral rotavirus vaccine for diarrhea, oral polio vaccine. So we already know how much the oral polio vaccine has been effective in eradicating polio from parts of the world. And yellow fever vaccine, again a very effective vaccine, and oral typhoid vaccine. So all these vaccines are examples of live attenuated vaccines. They give a very strong, long-lasting immunity. BCG, MMR, intranasal influenza, oral rotavirus, oral polio, yellow fever, and oral typhoid. So this is the mechanism of action of live attenuated vaccine. The wild viruses and bacteria, they are attenuated by repeated passing in the cell cultures or animal embryos. They undergo mutation and weakening. The virus is transformed from the wild type to the vaccine type, and then it comes to be known as live attenuated vaccine. Then injection or oral dose of a small dose of vaccine virus or bacteria. The patient then undergoes vaccination, replication of the vaccine virus or bacteria in the host. Then there is induction of an immune response, and this immune response actually protects against the real infection. Another type of vaccine is inactivated vaccine. So in inactivated vaccine, this type of vaccine utilize pathogens that have been killed, often by heat or chemicals, to stimulate an immune response. So the pathogen is inactivated either by heat or by chemicals, and making it inactivated so that it cannot cause the disease, but it can still trigger the immune response. The immune response is generally weaker compared to the live attenuated vaccines. This type of vaccine may require booster doses to maintain long-term immunity. Examples of inactivated vaccines are rabies vaccine, hepatitis A, and intramuscular influenza. So remember that intranasal influenza is a live attenuated vaccine, whereas intramuscular influenza is an inactivated vaccine. Examples: rabies, hepatitis A, and intramuscular influenza. So this is how the inactivated vaccine works. So virus has been killed with the help of heat or any other chemical agents. So the virus is inactive, but it is strong enough to trigger an immune response. However, the immune response is weaker than that which is induced by a live attenuated vaccine. Another type of vaccine is toxoid vaccines. So these toxoid vaccines, they are based on detoxified toxins produced by the bacteria. So these vaccines are actually made of the toxins which have been detoxified, and these toxins are actually produced by the bacteria. But these toxins are strong enough to stimulate the immune system. The immune system is trained to recognize and neutralize the toxins without being exposed to the harmful effects. It provides immunity against the toxic effects of infectious diseases. So booster doses are often needed to maintain the immunity over time, similar to that of inactivated vaccines. So here also in inactivated vaccine and toxoid vaccines, booster doses may be required. Examples are the DPT vaccine, that is the tetanus, diphtheria, and pertussis vaccine. Now, coming to the subunit and the conjugate vaccine. So, this was what was asked in the question. So, what is a subunit vaccine? The subunit vaccine utilizes only part of the pathogen to generate an immunogenic response. It focuses on specific components of the pathogen which are most effective in eliciting an immune response. So, this subunit vaccine, it comprises only a part of the pathogen which is strong enough to generate the immune response. On the other hand, the conjugate vaccine, actually the bacterial polysaccharide is not that much immunogenic. So we need a protein component to generate the immune response. So this conjugate vaccines, it links the poorly immunogenic bacterial polysaccharide outer coat to the protein to enhance the immunogenicity. So the attachment of a protein, it improves the immune response to the bacterial polysaccharide by attaching them to the proteins. So this is how a subunit and conjugate vaccines work. The subunit vaccines, they use a portion of the bacteria or virus to cause an immune response independent of its virus or bacteria of origin. Elements of subunit vaccines can be protein, polysaccharide chains, or a combination of this. So how does the protein vaccines work? So these viral proteins are isolated in a lab. They are mixed with an adjuvant or an immune system stimulator, and they are injected into the body to cause an immune response without the virus that makes you sick. So vaccine is released in the body. Protein is taken up by the antigen presenting cell and displayed on the surface as an antigen. Immune helper cells identify the antigen and trigger an immune response, giving rise to the immunity against the real disease. So examples of conjugate and subunit vaccines are, so conjugate vaccines which attach a protein to an outer polysaccharide are pneumococcus, haemophilus, and meningococcus. So meningococcus was asked the question. So remember, conjugate vaccines examples are pneumococcus, haemophilus, and meningococcus. And subunit vaccines which use part of the pathogen to stimulate an immune response are hepatitis B and human papillomavirus. So very, very important conjugate vaccines, pneumococcus, haemophilus, and meningococcus, subunit vaccines, hepatitis B, and human papilloma virus. Now, the another type of vaccines, which we already know, is messenger RNA, the mRNA vaccines. So, mRNA vaccines became very popular nowadays because of the COVID-19. So, this mRNA vaccines, they introduce a piece of mRNA into the cells, which then produce a protein to trigger an immune response. The mRNA provides instructions for the cells to produce a specific protein that the immune system recognizes and responds to. Examples are COVID-19 mRNA vaccines, for example, those which are manufactured by Pfizer and Moderna. So this is how an mRNA vaccine works. Then mRNA is the part of the mRNA is injected into the host cell, and that is recognized by the immune response cells. And this mRNA, it is strong enough to induce an immune response. And examples of this are the quite recently manufactured the Pfizer SARS-CoV-2 vaccine. Now, the last part is a viral vector vaccine. So, this viral vector vaccine, they use a harmless virus, which is different from the target pathogen, to deliver critical parts of the target pathogen to stimulate an immune response. The viral vector carries genetic material coding for a pathogen's protein into the cells, which then produce the protein and trigger an immune response. It can be produced very rapidly in response to emerging threats. Examples are Ebola vaccine and the COVID-19 vaccine dose manufactured by AstraZeneca and Johnson & Johnson. So this is a viral vector vaccine. So it basically uses a harmless virus other than the target pathogen. And this viral vector, it carries the genetic material coding for the pathogen's protein into the cells, which then produce and trigger an immune response. And this can be produced very rapidly in response to emerging threats. So this is how a viral vector vaccine works. And lastly, we will discuss different types of influenza vaccine because influenza vaccine comes in different types. The types which are available are the whole inactivated vaccine, which contains the entire virus that has been killed. Split virion vaccine, the virus particles are disrupted by the detergent treatment exposing the antigens, and the subunit vaccines, which mainly includes the hemagglutinin and the neuraminidase proteins. So we have the whole inactivated virus vaccine, the split virion, and the subunit vaccine. Cholera and hepatitis B. The cholera vaccine contains the inactivated Inaba and Ogawa strains of Vibrio cholerae, and it includes the recombinant B subunit of cholera toxin. The hepatitis B vaccine contains hepatitis B surface antigen, which is adsorbed onto aluminum hydroxide adjuvant. This is prepared using the yeast cells through the recombinant DNA technology. Now, something which is known as valency of vaccines. So, valency basically refers to the number of distinct antigenic components or serotypes a vaccine can protect against. It specifies the extent of a vaccine's antigenic reach. So valency is basically the number of distinct antigenic components or the serotypes against which the vaccine can give protection. We have the monovalent vaccines. So this monovalent vaccines, they are protective against a singular antigenic component, conferring immunity against only one strain or subtype of a pathogen. For example, the measles vaccine, which can give protection against the measles virus alone. Then something which is known as multivalent or polyvalent vaccine. So this polyvalent vaccine, it comprises multiple antigenic components. It provides protection against various strains or subtypes of the pathogen. Sometimes it can give protection against multiple pathogens as well. For example, we have the quadrivalent influenza vaccine, which protects against 4 distinct influenza virus strains. Okay, so that was all about vaccines. So vaccines again important. So you have to read what is live attenuated vaccine, inactivated vaccine, toxoid vaccine, conjugate vaccine, subunit vaccine, mRNA vaccine, viral vector vaccines, and what are the different types of vaccines and which fall into different categories. Coming to the last question, that is question number 5. Which one of the following statements regarding toxoplasmosis is true? So this is a question on toxoplasmosis. Options are: it is a type of flagellate. Congenital toxoplasmosis results in optic nerve atrophy. Ceftriaxone should be used in HIV associated toxoplasmosis. The cat is the only known animal reservoir. Infection is usually self limiting. So the answer is E, that is, infection is usually self limiting. So, toxoplasmosis, let us discuss toxoplasmosis in details. Toxoplasmosis gondii is an obligate intracellular protozoan parasite. So remember, obligate intracellular protozoan parasite. So, it's an intracellular protozoa. It infects the body through the fecal-oral route, that is the gastrointestinal tract, lungs, that is by inhalation, and broken skin-to-skin contact. Now, what is the life cycle and spread of toxoplasma? Uh, in toxoplasmosis, the oocytes are released, which then develop into trophozoites. Now, these trophozoites migrate to various parts of the body, including the eye, brain, and muscle. So this, you can see this is the life cycle of toxoplasma. So cat is the definitive host. Cat will release oocytes, toxoplasma shed by cat for less than 2 weeks after infection. So these oocytes are released by the cat. Now, when the human being or other animals come into the contact with the infected oocytes, so they may come into contact either directly by, uh, y- uh, you know, um if they come into contact with cat feces or they come into contact with skin and by handling infected meat of infected animals, then they can undergo infection. So these oocytes, then minimum 24 hours for oocytes shedding feces to become infective for human beings. So these oocytes, they enter into the human body and then they develop into trophozoites, and these trophozoites can migrate to various parts of the human body, such as the eye, brain, and muscle. So this human being is an end stage intermediate host. And other animals, such as rats, can also be reservoirs of the disease. However, the primary animal reservoir is cat. Humans typically become infected through ingesting contaminated food or water, direct contact with infected cat feces, or handling raw meat from infected animals. Now, it is the clinical presentation of toxoplasmosis in immunocompetent individuals. Remember that in immunocompetent individuals, most infections are asymptomatic. Symptomatic patients typically experience self limiting infection. So remember that in immunocompetent cases, toxoplasmosis is mostly a self limiting infection. It becomes a serious problem only in those with compromised immunity. There may be symptoms which is similar to infectious mononucleosis, such as fever, malaise, and lymphadenopathy. The less common manifestations can include complications like meningoencephalitis and myocarditis. Now, diagnosis and treatment. Serology is the investigation of choice for diagnosing toxoplasma infection. Treatment, no treatment is usually required for immunocompetent patients. Treatment may be necessary in cases of severe infection, like those involving the heart and the brain or the eyes, and treatment is usually necessary in immunosuppressed patients. So, how does toxoplasma manifest in HIV or immunosuppressed patients? So, in HIV and immunosuppressed patients, cerebral toxoplasmosis is a very common opportunistic infection. It accounts for around 50% of cerebral lesions in HIV patients. The common symptoms include constitutional symptoms like fever, malaise, fatigue, etc., then headache, confusion, and drowsiness. CT scan or MRI is the diagnostic modality of choice for diagnosing cerebral toxoplasmosis. In the CT or MRI, you can find single or multiple ring enhancing lesions. Mass effect can also be seen in some cases. The treatment regimen is usually sulfadiazine and pyrimethamine, and at least 6 weeks duration of sulfadiazine and pyrimethamine is required. So this is how the imaging findings of cerebral toxoplasmosis appear. As you can see, various ring enhancing lesions in the brain. So in HIV and immunocompromised individuals, cerebral toxoplasmosis is very common, and they manifest as multiple ring enhancing lesions. Toxoplasma can also affect the retina, and immunosuppressed patients usually develop a chorioretinitis secondary to toxoplasmosis. So as you can see, this is a fundus picture which is showing chorioretinitis due to toxoplasma. Congenital toxoplasmosis can also occur due to transplacental spread of toxoplasma from the mother to the fetus. The effects on the unborn child can be neurological damage, cerebral calcification, and hydrocephalus. There can be certain ophthalmic complications as well of congenital toxoplasmosis, which can manifest in the form of chorioretinitis, ophthalmic damage, retinopathy, and cataracts. So that was all. So till now we have covered 5 topics, and those were the zoonotic infections like tularemia. Then we talked about malaria, what is severe malaria. Then we talked about chlamydia. We talked about vaccines and toxoplasma. So please go through these 5 topics. They are very, very important for your MRCP, both part 1 and part 2 exams. And we will continue with the infectious disease part. And I'll soon come with another video covering infectious disease part 2. Thank you very much.